Hello, I'm Dr. Rafael Escamilla, professor in the Doctor of Physical Therapy program and director of the Biomechanics Lab here at California State University, Sacramento. Today we're going to be examining the structure, function, and pathology of the dorsal scapular nerve. This is Justin. He's one of my Doctor of Physical Therapy students. He's going to serve as a model. The dorsal scapular nerve originates from the brachial plexus. Specifically, it originates from the C5 ventral rami and often has contributions from the C4 ramus as well. So primarily C4, C5 ventral rami. And it's motor only. So the only muscles that innervates are the levator scapula and the rhomboids. So to illustrate this, we're going to have Justin go ahead and turn around for us. And I'm actually going to use the scapular bone and the pin to represent a force vector. So the dorsal scapular nerve is going to pierce the medial scalene muscles in the posterior triangle, and then it's going to run down and enter the deep surface of the levator scapular muscle. So we'll overlay the scapula right where Justin's scapula is, so you can see it a little bit better. So the origin of it is going to be from the transverse processes of T1 to T4, so right up in this area here. And then it's going to come down and insert into the superior angle, dorsal surface of the scapula. Now it's important to realize when a muscle contracts, it exerts equal and opposite force, both at the origin and the insertion. So it's trying to move both segments. In this case, both segments indeed can move. Sometimes they cannot. So we're going to use this pin to represent a force vector to kind of show the direction that a segment might move. So if we put this at the transverse processes down to the superior angle, this is the direction of the force acting on the head. So the direction is going down and back. So, and it's also going to the side. So from the viewer's perspective, it's going to the left. Okay, so part of this force is going down, part of it's going this way. So the part that's going to the left will actually pull the head to the left. So go ahead and laterally flex to the left. And we call the levator an ipsilateral lateral flexor, ipsilateral. So it flexes to the same side. Left side flexes to the left. Also, this force vector, part of this force is going back this way. So remember, the transverse processes come out a little bit. So if you have a force going back, it's going to have a force over a distance, moment arm, that produces a torque that's going to want to try to turn the head to the left. So go ahead and do that. It's an ipsilateral rotator of the head. And finally, you have a levator scapula on both sides. If they're both going posterior, then it wants to pull the head back. So it extends the head. Go ahead and extend the head. Those are the three actions of the levator scapula acting on the head. Most of the time when people think of the levator scapula, they don't think of those actions. They think more of the actions on the scapula. But in this case, both the origin and the insertion are movable. Now let's go ahead and make a force vector at the insertion and look at the actions of the scapula. You can see the force now going from the superior angle up to the transverse processes. And most of this force component is superior. Most of it's up if you resolve it into components. And a lesser amount is going in. But in simple terms, it's going up and in. So that's the direction it's going to move the scapula. When it's moving up, we call that elevation. When it's moving in, we call it adduction of the scapula or retraction. So we'll have Justin go ahead and demonstrate both those movements. And there we go. It's a deep muscle. It's deep to the trapezius. So obviously the trapezius is helping too. So if you have a pathology of the nerve, you'll still be able to elevate with the trapezius, upper fibers in particular, but there could be some weakness there without the levator and the rhomboids, because both those muscles produce an elevation component. And the final thing it produces, and this one's a little bit tougher to see, is a rotation component. So you have, again, your force vector here, and then you go somewhere in the scapula is going to be an axis of rotation. And in this case, let's say it's right around here. It's hard to see, but the line of force is just to the left or just to the right. It's kind of hard to really see exactly where it's at. It almost goes through it, but it actually produces a downward rotation torque when it contracts. So to produce a downward rotation torque, it'd have to be just to the right. So if we make it down, going just down in this area here to the right of where my finger is, then you have a little moment arm here, a force times a moment arm, that will downwardly rotate. So the force again is going up in this direction over a distance, and that gives you a downward rotation like this, where the inferior angle actually moves in. So go ahead and demonstrate downward rotation. There we go. And if his arm is elevated to begin with and now downwardly rotate, now you can see that inferior angle come in. So you can do it with the arm down at the side, or you can do it with the arm elevated to begin with. So that's the functions of the levator scapula. It's a C3, C4, C5. So the C4 and 5, it comes from the brachial plexus, and then it also gets contributions from C3 as well. Then, once it's done with the levator, it's going to come down and innervate the rhomboids. So the rhomboids have a minor and a major. So the origin of the minor is right up here at C7, very prominent bone, the spinous process that you can feel, the most prominent process you can feel actually in the neck. And then right below it is T1. So spinous processes, C7, T1, and then it's going to come down and insert into the root of the scapula. The root is formed by, this is the spine, when it comes all the way over to the medial border, right at its end, that's the root. Okay, so that's where the minor is going to be, going just like this. And notice that it's also, the force vector is also going up and in. So it has the same action as the levator, but it has a more of a inward component than the levator, which had more of an upward component. Then the rhomboids major is going to go from the spinous processes of T2 to T5. So right down in this area here. And then the insertion is going to go the entire length of the dorsal surface of the medial border, all the way down to the inferior angle. So the fiber is going to be going up like this. Again, more of a 45-degree angle. So if you resolve this force vector into components, then you have almost an equal amount of force going up as you do going in. So same actions, it elevates the component going up, and it retracts, going in and demonstrate elevation and retraction. There we go. That's what the muscle is doing. Now it also does one more thing that the levator does, but it does it better, and that's downwardly rotate. How does it do it better? Well, it produces a bigger torque. Torque's a function of force and moment arm. It's a bigger muscle, so it generates more force, and it has a better moment arm. For example, let's put the fibers, look at the lower fibers for a second. So you have a force vector here, and then if the axis of rotation is right here, then the moment arm is a perpendicular distance from the line of force of the force vector to the axis of rotation. So it's a pretty big moment arm compared to the small one we saw with the levator scapula. So this is force over this distance wants to rotate the scapula downward so the inferior angle goes in. And going to demonstrate that again, the downward rotation. So the rhomboids is a more powerful downward rotator. So if you do have a lesion, an injury to the dorsal scapular nerve, what you might see the biggest deficit is in downward rotation. Not as much in elevation and retraction, but you still have the powerful trapezius muscle. But you could lose downward rotation because the only other muscle that really downwardly rotates is the pec minor, which contributes some, but you've lost a bigger contributor in the rhomboids. So that's a summary of the structure, function, and pathology of the dorsal scapular nerve.